This is a case of a 25-year-old male who presents with jaw pain and headaches. He has a history of wearing multiple night guards for severe clenching. In 2012, the night guard broke and he was without it for 2 weeks. He awoke one morning and could not close his mouth. He saw several dentists and MDs and was given different medications which did not help his pain. He then saw a neuromuscular dentist who gave him an orthotic to wear day and night. The treatment did manage the symptoms as long as he was wearing the appliance. He later had an oral surgeon remove his wisdom teeth, and the TMD pain did resolve except for ear pressure, so he discontinued wearing the full-time night guard and had a nighttime appliance fabricated. Several months later, while in school, he awakened with a tight jaw. So he went back to the neuromuscular dentist and again started wearing the full-time night guard. It did not help him with the severe head and ear pain. A couple of months after that, he saw an orofacial pain specialist and he was given trigger point injections which helped with some of his symptoms. But he still had left jaw pain. The orofacial pain doctor recently placed him on Topamax for his head pain, but he has yet to see results. He is here today because he's home from school and cannot see his regular orofacial pain specialist for a couple of weeks and would like to try a trigger point injection since it gave him the most relief in the past. The history of present illness. So the onset of this pain was in August 2013. The location is both sides on the jaw area. The quality of the pain is sore and achy, and it's really more of a continuous pain, moderate to severe in intensity. He believes the causation is stress. Heat makes the pain better, and what makes the pain worse is actually increased stress. His headache history onset was about the same time as the jaw pain onset. The location of the headaches are bilateral temple and right eye. It's more of a pressure type of pain, and it's also continuous. He believes that the TMD pain is actually causing the headaches. Nothing really makes them better, and stress makes them worse. Medical history. His medical history is positive for psoriasis, oral herpes, anxiety, and depression. His current medications are Topamax 25 milligrams, Voltaren gel, which he has been using on the TMJ area. He's tried Klonopin, but it increased his anxiety. No known drug allergies, and no surgeries. Sleep history is normal. He has a family history of diabetes, and for social history, he does admit to clenching his teeth, facial neck tension, and he has tried 5 night guards in the past, which he has worn through. During the extraoral exam and the palpation of craniofacial muscles, it was shown that the right masseter had a moderate pain to palpation that shoots upward from the angle of the mandible. He also had moderate pain to palpation of the left masseter, but no referral. He showed mild pain to anterior temporalis on the right, and the right-left temporalis tendon did show severe pain to palpation, and the left SCM muscle was mild pain. When palpating the temporomandibular joint, the left dorsal condyle did give severe pain for the patient. There were no joint noises. He did have a scalloped border of the tongue, which is usually indicative of clenching. The max pain-free open was 36 millimeters, which is a bit restricted, but he was able to open to 45 millimeters with pain. And the right-left lateral max was 10 plus millimeters, which is normal. In the intraoral exam, there were no significant dental attrition, Posterior tooth contact, however, had no contact on the left side with Mylar. The existing night guard does not have anterior contact, but does have even posterior contact. Neurological and psychiatric. Cranial nerves 2 through 12 were tested in this case. The patient states he has had some visual changes in the right eye in the past few days. He also had decreased sound in his right ear. He said this happened a year ago and saw an ENT, but no problems were found. Cranial nerves 2 through 12 were normal except for cranial nerve 2 and cranial nerve 8. Also, patient has been seeing a school therapist for anxiety and stress. He stated he did not benefit from that treatment. We received this radiograph from his dentist, which was taken recently. Unfortunately, it's a bit unclear and we cannot assess the TMJ area. For the assessment, I diagnosed myofacial pain and capsulitis, tension type headache, tendinitis, and strained neck. I will be focusing on the myofacial pain in this case for this patient. I will also treat the capsulitis as well. My treatment plan is as follows. Number 1, myofacial protocol including avoidance therapy, end position and stretch, and heat therapy. Number 2, I recommended a trigger point injection. Patient agreed, consent was signed, and I injected 0.5 cc's of 1% lidocaine without epinephrine into the right masseter at the angle of the mandible without complications. I also prescribed nabumetone for capsulitis. Told the patient to continue taking the Topamax to see if the headaches become manageable. And number 5, recommended a brain MRI to rule out any brain pathology. He states that this has been discussed with his primary care physician as well recently. I recommended referral for physical therapy, and he will be seeing a physical therapist near his university. I also discussed psychiatric referral for this patient for stress management. And I recommended the patient to call our office in 1 week to give us an update. He will be back in school, and a follow-up visit will be very difficult for him. For the prescription, I prescribed nabumetone 500 milligrams, 28 tabs, take 1 tablet twice a day for 2 weeks. And again, recommended the patient to call our office in 1 week to give an update. Visit number 2. Unfortunately, the patient did not call back. I left multiple phone messages, but the patient failed to return our calls. Well, what is myofacial pain? So we detect myofacial pain by palpation of the muscles. It reveals top bands, trigger points within the top band, and referred pain sensations upon the sustained compression of the trigger point itself. Needle EMG studies report that sustained spontaneous motor end plate activity, which can be found within about 1 to 2 millimeters of the hyperirritable trigger point in the muscles. And the activity is shown to be increased by the sympathetic nervous system. So in this case, we gave a trigger point injection. Well, what does the research say? A study by Venancio was conducted to assess trigger point injections using Botox, lidocaine, and dry needling injections for the management of local pain and associated headaches. In this study, 45 myofascial patients with headaches that could be reproduced by activating at least 1 trigger point were randomly assigned to 3 groups: Botox, lidocaine, and dry needling. Statistically, all of the groups showed favorable results for these treatments. So it was concluded that because of the reduced cost, lidocaine could be adopted as a substance of choice, and Botox should be reserved for refractory cases. Well, what are we achieving with the trigger point injection? Well, one thing is we're trying to break up that top band where the trigger point is. Why are we using lidocaine? Well, lidocaine is a myotoxin that causes a microinjury, allowing our endogenous endorphins to be released and to help with the pain. The other reason why lidocaine is helpful in the trigger point injection is because we're numbing the area and we can do more effective stretching of the muscles while the muscle is actually numb. Thank you.